Hello and welcome to Yodo. I'm Dr. Bone. Today I have information for families and people who work with patients that have dementia. This is a discussion of some common symptoms, things to watch for, and possible interventions. Some types of dementia are hallmarked by specific symptoms and signs and behavior issues. Nearly all types of cognitive impairment, though, have a few things in common, even when the disease causing the impairment is different. Alzheimer's disease is the most common memory impairment process. It progresses slowly and smoothly over a long period of time, sometimes 15 to 20 years. Thus, it can kind of sneak up on patients and families. The patient may not be able to tell that it's happening, and the family may not be able to discern and pinpoint a point in time when the change actually occurred and when the patient lost ability for independent living. Sometimes they're actually caught off guard when they hear that diagnosis. There are multiple other kinds of dementia, and some of those progress more rapidly. Some of them have a stair-step kind of decline, and we call that the sawtooth pattern of decline. And those families may not be as surprised when they hear the diagnosis of the cognitive impairment. Being proactive and getting medical attention does really help the patient as well as the family. For patients and families that realize there is a cognitive impairment decline in memory, if they seek out and receive high-quality early intervention, that trajectory of decline can be changed. Sometimes the process can be completely halted depending on the cause of that memory impairment. It is not common for them to regain memory once it's lost. That memory can't be retrieved because those cells may have been damaged to the point where that memory is gone forever. With some memory diseases, the memory that they have may not be accurate. Keep in mind that not every person with a memory impairment is going to behave the same way. Each individual may not be the same way morning, afternoon, and night. They may have periods of the day where they're very good, and they may have periods of the day where they really struggle. Just hour to hour, sometimes it can be different. We must consider and respect the patient's perspective. Patients may be very aware that they have memory impairment, and it can be more than embarrassing. They can withdraw from activities and functions, and that withdrawal will actually worsen the problem. When working with a patient that has cognitive impairment, it's best to attempt to maintain that high level of respect, to allow them to continue to remain independent and to maintain their dignity. That's imperative. Consider your words and actions, and above all, don't treat them rudely. Our poor behaviors are likely to be met with mood changes and abnormal behaviors from the patient. They might become withdrawn, they might retaliate, they could exhibit anger or even aggression. You have to remember that these individuals were leaders, heads of household or a business, and many of them served in the military. That is part of their persona, and they can still remember some of that authority. Not to be harsh, but as we age, our cognition does slow, even without memory impairment. And we need to be direct and reassuring, and it's best for patients that have cognitive impairment for their life to be simplified. It's frustrating not to have the ability to use a device, something simple that you've always used, such as a telephone or a television. Those things have changed over time, so learning that new skill can sometimes be difficult for someone with cognitive impairment. One of the more notable truths about a person with dementia processes is as that disease advances, we can become more childlike, not just with our primitive reflexes that will return, but also with our moods. And a temper tantrum in a 5-year-old can be seemingly very similar to a temper tantrum in an older person with cognitive impairment, but you've got a full-size adult with that memory that they were a person of authority. Rather than orientation and correction, a better way to treat misinformation, which may be a new way of thinking for you, may be to give them a plausible reason for why they think may not be applicable or may not be true. The goal is to provide an environment that promotes the patient's individuality and retains their independence with respect to their identity. The people that they know the best, have the longest relationships with, are typically the ones that they're going to allow themselves to rely on. But you don't want to argue with them. You're going to consider the outcome and what's going to be accomplished by your words and correcting them. So sometimes reorientation or correcting them and to provide factual information may not be appropriate. If they don't recall that a loved one has passed, you may want to not reveal that to them every time they ask about it, because it could cause them heartache that they forgot such an important event. How could that happen and they not retain that information? All that being said, simplifying the patient's life and surroundings, laying down and maintaining routines early in the process of cognitive impairment can provide tremendous advantage for the patient as well as the family or the caregivers. As memory function declines and cognitive speed slows, having that regular, ingrained routine can bring comfort and reassurance to the patient and make everyone's life a little bit more simple and easy. Therefore, routine is a must. Keep your loved one in a routine. They're going to find that very comforting. We're mammals, and we may think we like a job promotion, we may think we like a new car, but everything new we get requires us to learn, and that can be more stressful to someone with cognitive impairment. Like other mammals, your dog likes to walk the same way around the house, your dog likes the particular window to look out of or bark out of, your cat wants to sleep in the same chair and eat at the same time, and we're mammals too, and routine for an elderly person is an advantage for them. Patients may like to wear the same clothes, they may like to deal with the same people. They may have preferences for activities or things or events that they participate with, and they may like things done on a particular timetable. We should observe that and respect that. It's very comforting for them to have a routine. So let's break that down just a bit. Let's talk for a moment about clothes. Some patients can develop particular clothing preferences, and not unlike a child with an item that they want to have with them, whether it's a blanket or a toy, some patients with cognitive impairment can also have preferences for their clothing. If that happens, just go with the flow. Buy 3 or 4 identical tops and bottoms that are even the same color. You can mark them inside so that you can tell the difference, but that's more difficult for the patient. And then after they change clothes or take their bath, you can put on the clean ones and you can wash the soiled ones. The routine for changing clothes and having a bath really needs to be kept up with. Even if it's just bathing 2 or 3 times a week, or even if it's just sponge bathing, you're going to want to keep that routine, because as patients are allowed out of their routine, sometimes tasks that are not pleasant for them, they're not going to want to restart that routine, and it can become more difficult. Changing clothes and having a bath are crucial for good care and good hygiene. Poor skin care can lead to dry skin, wounds, and infection. Then you've got a doctor's visit and you may need medications, and a downhill spiral can begin to occur, or you can see that trajectory begin to change for a period of time. Let's talk a little bit more about the bathing. Some patients may become quite resistant and reluctant to bathe or to change their clothes. Each situation is a little bit different, but there are things that you can do to help reassure your loved one and help reassure the patient. Staying in the routine is for sure one of them. When it's the day of the bath, remind them today's the day you wanted your bath. Have warm water, have the bathroom warm, make sure that it's well lit, that you have plenty of towels available, and that you're going to be there to help them. You might ask the patient, which one is the soap that you liked? Is this the towel that you like? Have them participate with that activity of getting ready for the bath. A non-slip mat, or if you need a shower seat, you might check with your physician to see if the insurance would cover for a shower mat or a shower seat or a safety bar, because patients do feel reassured if they've got something that they can hold on to. And also one of those removable shower heads. Those are convenient for giving the shower or giving the bath. Giving gentle reminders about that it's time for the bath, or this is the bath time, that it's nearing, and be very matter of fact, having them help you get ready and remind them that you're just there to assist them, that they're doing it for themselves because they want to maintain that level of independence. Being matter of fact and not implying an abnormal level of intimacy for the bath or making rude comments about their body physique. Don't remind them of past experiences or issues with bath time. If your loved one is receiving extra help from a vendor, such as a hospice agency or a home health agency, or maybe you've got a private pay aid service that comes in to provide the bath, you will be amazed at their professionalism and how they can take that task on for you and the family member. Patients can build great relationships with that aide, and those aides are trained to give that intimate bath, do so in a professional manner. And where you might have had a little bit of a conflict or a confrontation with your loved one, they can make it seem so smooth and so seamless that it can really have its own value. Hospice agencies are really sensitive to the relationship that the aide builds with that patient, and generally they're very reluctant to change the aide that comes into the home to provide that service. Incontinence is another very common issue. Anyone can have issues with incontinence, but having cognitive impairment may worsen that already apparent issue. The signal that comes from the bladder to the brain to let you know that you need to go to the bathroom and that manages that bladder and urethral control becomes impaired. And holding the urine may already be impaired. So when the signal becomes impaired and they already have an issue, it just makes it a little bit worse. Patients may not have full control, and a leaky bladder is an embarrassment as well as a potential risk for skin irritation or possibly infection. It's better to have a leaky bladder, though, than one that doesn't empty. Causes for urinary retention and having an overly full bladder are multiple, and it can lead to that bladder being full. The patient can become agitated or restless, and if that bladder is not emptied and it's not addressed, it can actually cause kidney damage and renal impairment. So we need to adapt and go with the flow as far as incontinence is concerned. You would not expect a toddler to be fully continent, so don't hold your cognitively impaired loved one to an unrealistic expectation about their bladder skills. Women have a very short urethra, and if she's been pregnant before or delivered a child, I personally find it pretty miraculous for any female to have that bladder control after a pregnancy or after delivery because of what the perineum goes through during pregnancy and during delivery. Over time, that loss of estrogen that occurs really after about age 55 or 60 can have a significant impairment on that vaginal tissue, on the urethra, on the bladder control, and it also that estrogen helps us maintain our normal bacterial flora, and it helps us defend against infection. So as that estrogen level comes down, our natural defense decreases, our bladder can become colonized with bacteria, and we can suffer from other issues of vaginal dryness as well as further loss of incontinence. For the fellas, the prostate and bladder have their own issues. The prostate is about the size of a walnut, and the urethra goes right through the center of that. And over time, 50, 60, 70, 80 years, that prostate gland can get stiff and it's not pliable. And the enlargement is not just that the whole gland gets larger, but it actually enlarges toward the center so it can squeeze on that urethra. Thus, the bladder has to push really hard to empty the contents of that bladder out through that urethra where the prostate is squeezing it. Think of a straw that's being pinched from the outside. With a change in position, males or females may lose a few drops of urine, or because of a restriction, the bladder emptying could be incomplete, and these issues do need to be addressed. If the prostate or a male's bladder becomes colonized with bacteria, they also are at increased risk for those infection symptoms. But we don't treat, and we certainly can't test for cure because we can't get rid of that colonization. So just what is colonization of the bladder? That's when bacteria has reached this point where it is actually living in the bladder. It doesn't necessarily cause infection all the time, but that risk is present. So we don't test for cure. If the patient has symptoms of a bladder infection, the urine becomes murky or cloudy, or there's blood tinge in it, the patient has change in their incontinence, they have a fever, become agitated, these symptoms can imply that the patient's bacterial colonization has now transferred into an infection, and testing then is warranted, and we can make a decision as to whether or not treating that bacteria is warranted with an antibiotic. We don't just give antibiotics indiscriminately because of the risks that are associated with treating somebody with an antibiotic. So please don't add insult to injury. It is just pee, for crying out loud. Now for a bit about basic dementia communication, interactions, and advice. Agree, don't argue. Divert, don't reason. Distract, don't shame. Reassure, not lecture. Reminisce, but avoid the word remember. Reassure what they can do and avoid the phrase you can't. Ask, don't demand. Encourage them, don't condescend. And don't force them. Use methods that gain the patient's agreement. Let's discuss these symptoms and some interventions. One of the most common symptoms that patients have that is frustrating for people who work with them or live with them is the repeated questions. This symptom can occur early on, and it typically progresses with time. This symptom is certainly one that can trigger the family members or the people that live with a person, whether it's in an assisted living facility or an independent living facility or a nursing home. that has cognitive impairment, when they ask those same questions over and over again, can become really frustrating for other people. Keep in mind, the patient is not doing it to annoy someone. They may truly not recall that they've asked that question before. And if they don't recall that they've asked the question, it's likely they don't recall that you've answered that question. It's better not to say, I told you, we just talked about this, or you remember. Better suggestions of things to say are, I'm glad you remembered to ask me that, and then tell them that response again. I do not remember. That's something important. We should look into that. Let's write that down because that's important, and I want you to have that information, and then maybe write it down on a card. Brainstorm with others or possibly with the patient themselves about how you can assist their memory and how you can help them answer those questions without having to ask. Sometimes the patients will have good suggestions. Some patients have one question in particular they ask, or they have one particular time of day that is an issue for them. And that's where the term Sundowners comes from, because it's usually in the evening, sometimes earlier in the afternoon in the winter when the sun is going down early, and sometimes later in the summer when the sun is going down later. But you need to identify those issues and then develop techniques to help manage them. Learning the pattern of the patient can help prepare everyone and help diffuse a situation before it occurs. Keep in mind that if the patient doesn't recall they've asked a question, they're likely not going to recall the response that you gave them. If you've got something that works for them, just say the same thing again. As with young individuals, kids do not like to be told no, and so telling an elderly patient that has some cognitive impairment no is likely to be met with resistance as well. For special considerations, patients that have more than one language, they may be asking their question in both languages, and they may expect that response in both languages. So you can just memorize that response, or again, write it down, and then present them with that response when they begin to ask that question. I once had a patient at the nursing home, and every evening at about the same time, she would come to the front desk and she would tell them, I hear a baby crying. Don't you hear the baby crying? I need to go home and get my supper ready because my husband's going to be home and I need to feed him supper. I need to have dinner ready. One evening when she came up to the nurse's station and presented us with that concern, rather than reorienting her, the nurse and I presented her with the information that her husband had just called and left a message for her that he was held up at work and that he advised her to have some dinner with her friends. Well, she decided that many of her friends were going to have dinner right here. She called it the restaurant in the dining room, and she had dinner with them. It worked so well that we wrote that up on an official memo pad, laminated that piece of paper, and then when she would come up in the evenings, we would give her that, tell her he just called and left this message for you, and then she would read it as if it was the first time she'd ever read it, give us the message back, and she would go have dinner with her friends, and we would sail through that part of the evening without difficulty. So sometimes you have to look for unique ways that help your patient be more comfortable with what's happening. Other communication tips: using the person's name can soothe them and reassure them that you identify with them. Consider their vision and hearing. If they have a vision impairment or a hearing impairment, you want to talk loudly so they can hear you, but not yell at them. Don't use harsh words or a harsh tone to your voice because they can interpret that and they can understand that. You're going to want to communicate with them with good eye contact. In the home environment, it may not be as important for someone to introduce themselves to the person because they're going to remember you. However, for an individual to give them that warning that this is what our purpose is, we're going to have dinner, we're getting ready to take a bath, we're going to have our clothes changed, you're going to be participating in this activity too. You're almost asking permission, but you're telling them in a kind way that this is their responsibility. Sometimes staff can become upset with a patient because when they've presented those activities to somebody, they've asked them in a way that's offensive to the patient. So knowing your loved one, knowing the patient and what they respond to is very helpful. Keep your words simple. Look for humor when you can find it. Be mindful and appropriate of the method of contact with the patient. Volume is appropriate for them to be able to hear, and then using that kind tone in your voice. Get gentle confirmation from the patient that they understand what you've told them is going to happen. And then if you can tell by their facial expression that they're upset or they're angry, name the emotion and help them address why they feel that way. For facility staff, if you're not working with that patient on an ongoing basis, and it's the first time you've seen them today or this afternoon, Reintroduce yourself, address them by their name, and state your purpose. When listening to a patient with dementia, you want to consider what they're trying to communicate with you. They may be struggling with word finding. They may have trouble putting those words together in the sentence to express themselves. So learn their preferences for how they like their communication to be assisted, and then be respectful of those wishes. When words are missing or speech is garbled, like mine is right now, work with them the best that you can without correcting them in a rude way. You can make gentle suggestions, but avoid giving them the wrong impression of what you're trying to accomplish. Subtle emotions often become difficult for them to express, but strong emotions and strong words, particularly foul language in particular, can remain intact for a long period of time. Music is the last pathway lost, and they may prefer music from their youth, not necessarily liking the music that you prefer to listen to, and that can go a long way to making things easier. I once worked with a patient at the nursing home, and all communication was difficult for her, but if we would sing our question to her, she would sing her response back to us. So if we would sing to her and ask her about if she was hungry, what she would like to eat, tell her that we were going to have her bath get ready, then she would sing her response back to us, and it was a great way to communicate, even if we didn't sing very well. Patients may have preferences, but because of their desire not to burden others, they may not be as willing to communicate that. Often patients may realize that they have a particular way of wanting an issue to be handled, and they're fearful to voice those preferences as because they don't want to be a burden. But as time passes, they may no longer realize about those preferences, and they can become rigid without explanation. Their ability to be flexible will decrease over time. They may no longer have the ability for adaptation. And sometimes these preferences can make sense to you, and sometimes it may not make sense at all. This adds to their frustration, and then their behaviors can spiral out of control. If we learn their triggers and help them adapt, we can be able to avoid a lot of these behaviors and keep them at a minimum, and we don't have this escalation of behaviors. Some patients may react better to a particular individual, and I call this person the anchor in reality. And that person may need to be present often. Just seeing them can help reorient the patient. That person may need to be available anytime, night or day sometimes, to soothe the patient. And that burden can weigh on the anchor person because they may not have the time they need to take care of themselves. We need to consider ahead of time the what-if strategy when the anchor in reality is not available. What we want to do is try to adapt what that anchor person says or does, what that behavior might be like, and then we can try using that in certain circumstances. I once worked with a patient at a facility. We would call the spouse on the telephone whenever it was MedPass time, and she was available by phone. Sometimes she would be present, but that wasn't always possible because of the multiple dosing times during the day. But then she would talk with her husband, and they had a unique relationship because she would tell him on the phone, "Don't make me come down there. You better take that medication for those nurses." She could get away with that behavior because he knew her and their lifelong relationship. But our staff certainly couldn't behave that way toward him because they would have been met back with aggression. We also cared for a patient one time that he would identify his wife's face. His dementia was quite advanced. And so even though we had a picture of his wife that we had cut the eyes out of and had put on a tongue depressor, we could carry that picture into the room and give him his pills, and he would take them for his wife's picture. And we didn't have any arguments or discussion that was difficult. We do need to be mindful. We don't want to be offensive. Reorientation to what's happening, we can be flexible with that. We need to consider the activities that the patient is participating with, and we need to have them in familiar places, at least with familiar people or items. We don't want to be a prisoner in our own home or at the facility, but sometimes a bustling area with a lot of overwhelming sights and sounds can really overwhelm the person. If we do need to go out with our person, we're not going to want to go at peak times. Sometimes a physician office visit is better if we can go early in the morning or later in the afternoon, and a lot of times physician offices are sensitive to that. New things and exploring is not necessarily good with a patient with cognitive impairment. We need to manage our expectations, and we need to understand what the patient's expectations are. We need to be flexible because the patient might not be. Possibly an activity to help distract the patient can be used. These can be patient specific. For facilities and patients that are in memory units, those activities can become quite familiar for the patient. They may be age specific and sometimes occupation specific. Activities that they can do with their hands and require simple concentration, such as drawing or coloring or sewing. Unfortunately for males, we can't get them hand tools because sometimes they can get frustrated with those hand tools and not use them for the intended purpose. That's just a few things that we've discussed today. There's much more to come. In summary, we have noted a lot of common behaviors for patients that have dementia, regardless of the type of dementia. And these can be concerning and very frustrating, both for the patient as well as the caregivers. Anticipating and having a planned intervention can help reduce everyone's stress. Plan for simple and easy familiar activities. Talking, reminiscing, quiet walks, watching G-rated movies, listening to music from the patient's youth are all good activities that they can be involved in. Develop and stick with a routine, but you've got to remain flexible because the patient will have good days and not so good days. Being prepared for how to adapt for the loss of people, pets, items, and even clothes, because these changes can be very upsetting for patients with cognitive impairment. Reorienting a patient sometimes is not the best choice, but going along with them or helping them understand why something is not possible. And we'll go into that more in other videos. But be respectful for your patient, do the best to go slow, and be patient with them. Please join in again for more information and suggestions on this big topic. Thanks so much for your time today. Bye now.